This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name is Joe Sam Robinson. It's my pleasure to have with us once again Dr. Buck Melton. Buck, we're happy to have you here tonight.
I'm a little casual tonight.
No, your political aspirations are well known in these parts. I've just, this coronavirus problem is having an impact on your political campaign, but I think you can come out of it in an okay situation if that reassures you.
Well, it's going to be a toss-up between Michelle Obama and me, and if Joe Biden manages to win and decides to retire 2 years in, I could get 10 years as president.
10 happy years.
10 years.
10 happy years.
So.
Well, it has its upsides. Mm-hmm. Well, maybe we could talk tonight about the coronavirus, which we're trying to talk about a fair amount since this is, I think, a world event. It really is a world event, similar to Pearl Harbor, the Depression, 9/11. And if you've been here on the planet a long time, as I've been, it really is a compelling event. Now, maybe tonight what we can do is I can toss you the football and you can ask me a few questions about the coronavirus, which I will discuss. Not because I'm a particular expert on this. In fact, it's sort of a joke to be a neurosurgeon discussing a communicable disease problem, but
unless we did zombies, because zombies always affect the brain.
Well, that's true, but I mean, I think it's worth an interchange. I think it would be useful to discuss that.
Yes.
So I'll ask you to ask me something about it, and I will start to run with it.
Well, I'll lead off by asking you, based on some of our past conversations, and I am somewhat sympathetic to this point of view, but I'm still trying to feel my way through this. I think that the problem that you keep trying to point out is that this thing has really done a serious number on the world economy. And the question, I guess that you can put it most basically is it worth it?
Yes.
And that's kind of imponderable because we don't yet know how serious this thing is, how communicable it is, the lethality rates, the experts are constantly changing things. So where do we come down onto it? On this balance between property and livelihood on the one hand and life on the other.
Oh, okay. Well, you threw me the softball. I'll hit it back to you a little bit. So actually, this is an issue of substantial consequence. And what we're getting from every corner are statements about this or that in regards to the virus. There's so much we don't know about it. And to make some decisions and maybe to pursue your query, we can go through and discuss three things of consequence. Number one would be testing. Number two would be transmissibility. And number three would be the lethality of how dangerous the disease is, those three issues. And after pursuing those three things, we could then come up with some treatment options that are underway now, control options, should I say. But I'll start out with some of the problems that faces our country, faces the world. And that's the testing problem. This is a terrible problem with testing. So we have all these difficulties. And the story that existed, let's say back in January in the United States, was that the CDC sort of controlled testing arrangements, and they were the state health departments, and they're very slow and cumbersome and very accurate. So,
and if I could interject there, is the problem? Well, I may be getting ahead of things. So
I
know that one problem is that they botched, they contaminated or cross-contaminated some of the tests, or so the allegation was. I'm wondering if the problem, if everything goes as it should, what takes a test so long? Is it the design or the production? Is it spotting the antibodies, or is it actually turning out the test?
Well, there are two separate issues here, I would say. Issue number one, just to say what happened, the CDC was in the process of coming up with a test, and they're really pretty good at it. The takeaway message was that their arrangements were contaminated because people were coming into their little alcove that contaminated it. So when the tests were sent out, they immediately said these tests are not appropriate, they're not accurate. Now these were the nasal swab tests, that's the frontline kind of deal that's out there. So those tests the things had to start over. They put this out to private enterprise to do this, and so varying kinds of tests have come up with varying degrees of selectivity and specificity. What that means is how accurate the test is to see if you do or don't have the virus. So that's the frontline thing that's out there. So that's a big, huge deal. And the takeaway story is we just don't have enough tests. There are not enough tests. So millions of people need to be routinely tested to get a handle on what's going on just with the swab. Now, some of the problems with that is there's quite an art form to getting the appropriate it's RNA that comes out of here. There are several steps in this to do it, and errors can occur in multiple places in getting these tests. So the accuracy of the tests are still not perfect.
Well, even if it works perfectly, this thing's a lower respiratory tract infection, and the swabs are only of the upper tract, so you might just miss the virus.
Not only that, the virus goes everywhere in the body.
Yeah.
So the virus can involve multiple organ systems. These little ACE receptors are located in the lungs and the liver and in the small intestine. So when people have this insult, multiple organ systems can be involved and commonly are. And so the ability to accurately say if you do or don't have this is somewhat difficult. But we certainly should have zillions of tests out there, zillions of tests, repeated tests. What goes on now, I think Dr. Kattner has discussed this a little bit, is, and it's not an uncommon story, a person has all the clinical symptoms of the coronavirus, and the tests come back negative, and nobody believes it. There must be some kind of error. So after several repeat tests, finally they get a positive test back. So there's a lot of errors involved in the testing apparatus, and the biggest issue is it's so hard to obtain the tests. Now, things are getting a little better, but I would say commonly in Macon it was taking a week or so to get test results back, 7 or 8 days. Now it's possible to get them back overnight under some circumstances. So the test can come back with some rapidity, and that's an important issue for many reasons. If a person has, let's say, multiple organ problems, the person may require a foot amputation, and the person is in the hospital for emergency surgery, and there's some evidence of a fever, then nothing can happen, nothing occurs with that patient until the coronavirus is ruled out, because the patient could contaminate the equipment in the hospital. So there are a lot of, it's very, very complicated. But the first thing that needs to happen for a decision maker or the fate of the world are these appropriate tests need to be out there, and they need to be a lot of them, millions and millions. And if you have a negative one first, it doesn't mean it won't turn positive. Anybody in the country should, with any question, should be doing this, having the test. And that's point one, the nasal swab.
Yeah.
And then,
and what's the bottleneck? Why is it so hard to get these tests? I mean,
that's a big question. Down here, far from the decisions of power, it looks like no one has. They have to gear up to do this, sort of like producing B-25s in World War II. The great American industrial complex needs to get rolling with this.
Yeah, and I understand that there's a time lag. I remember in 1940, FDR said we need to be producing 50,000 combat aircraft a year.
Yes.
We had our entire military inventory of combat aircraft when he made that pronouncement was 5,000, and he said we need 50,000 per year, and he was laughed at. By 1944, we were producing 75,000 a year. Now, a nasal swab is not a combat aircraft. It seems a lot smaller. So I'm just wondering, what are the steps in producing this test?
Once again, I'm a little bit out of my field, so I'll mumble a little bit about it. But that's needed, and the accoutrements to actually do the analysis are needed, which are a number of somewhat hard to get chemicals. So to put the whole apparatus together requires several steps, and it's complicated because so much of the apparatus is out of the country, being produced out of the country. So we see,
So in 1941, we have to send to China for parts for our combat aircraft.
Right, something like that. Right. Yes, that's true. And the other point
about reaping the whirlwind.
The other thing that happens with this is that the inaccuracy of the tests are so extraordinary that you have to be somewhat jaded about anything that's said, particularly in overseas countries. So the Chinese, to know the story, they sent zillions of their tests out to as being a good neighbor, trying to be a good neighbor, reasonable gesture. I appreciate it. Everyone appreciates it. However, the tests were flawed. So they sent all these testing kits out, and I think it caused big problems in Britain. It turned out they weren't accurate. So there's a tremendous problem with just the nasal swab part of it, which is the front line to deal. So when you see these statistics that are put out, maybe you watch them on television from Johns Hopkins, they need a little asterisk by these statistics because of the inaccuracy that's there, particularly in overseas countries. So the tests are very suspect, quite suspect, and there's so few of them. So I think in President Trump's recent bill through Congress, spearheaded by him, but a bipartisan arrangement, I saw a number, I'll say $10 billion going into testing. Well, for me, because the fate of the world is involved in viral control here, I mean, that's just de minimis. I mean, there needs to be a person that's the generalissimo of testing, kind of like Lord Beaverbrook, the guy in the UK that produced, he was in charge of producing Spitfires, and he just did it. There needs to be a person that's going to get these tests out there,
so
accurate, good tests.
We need a Harry Hopkins or a Bernard Baruch.
We need a person, a generalissimo of getting, it's very unsatisfactory and doesn't comport with the American Republic to have this terrible testing deal. I'll continue on my little tirade here. One of the things that happens is that it's said that the U.S. is doing more testing than any other country in the world. Well, the big deal is the amount of tests per population. So it's true, that is true. We've done more tests as far as we know than any other country in the world, but not
per capita.
Not per capita.
No.
And so we lag several Western European countries, and once again, the accuracy of the tests, big deal. Well, I've had that little tirade on that. That's point number one.
Transmissibility.
No, I'm not ready yet.
Not ready?
So I want to go to antibodies now.
Oh, okay.
So another crucial thing, this is a big deal out there, is getting tested for antibodies. Now, apparently this is available. So
this is a blood test.
This is the blood test that shows there are basically two antibodies that are out there that are of consequence. There's IgM and IgG. So when you have, if your body is fighting this infection, your IgM is going to be elevated. So it's a marker for you may have an active infection. Then after things cool down and presumably your body has learned how to control the infection, we go to an IgG, which would be a marker for the number of people that have had the infection. So those would be huge things to do. Now it's quite difficult, once again, to get these appropriate arrangements put together. And each laboratory has to go through sort of a range of normal story here. And the issue is, if these antibodies are up or down, how high do they have to be to say, well, for sure you're infected? How high does the IgM have to be in your individual lab arrangements? And then the IgG, can we say your IgG, your antibody is high enough that you've conquered the infection and that you're immune and that it's appropriate for you to go out in the world. And so getting a handle on the control of this and getting the right information for decision makers is understanding those numbers. So those are really important things. The generalissimo of testing needs to be jumping around with getting antibodies a level, and I believe that's now accessible. You can, it's starting to be available, and I think it's a big deal. So people, once these tests are out there, one could try and discover who might be immune, and we can, as we pursue this inquiry, I think we'd get some knowledge about how vigorous the immune system is in different subgroups in the population, which would be a big deal. So one of the things that can come out of this global testing, it's sort of the advantages that occur in war. So all these new things happen. We get nuclear power, I don't know, whatever, electricity, all kinds of good things happen accidentally in war that are to the benefit of society. I think if we really get into tremendous testing and trying to get a handle on this world epidemic, that's going to be a huge deal. All kinds of good things can happen. So right now, when we hear a politician say something or a decision maker, they're really hindered by the absence of data. That includes all the bright people that are helping the president, all those really knowledgeable poobahs from the CDC and NIH, really smart guys and ladies. But they lack appropriate information for the decision. So it really injects some questions sometimes into the right course that the world should take.
Well, if I can interject something there,
yes.
One of the reasons that we don't have the information is that we have, under the auspices of globalism, over the last 20 or 30 years, we have outsourced a lot of the means of production that we need to get the tests to get us the information.
Yes.
I've been preaching this for 20 years. This is just bad.
You know, we could sail that ship into a whole nother discussion about what's the appropriate national border, how appropriate are national borders, nation states, what's the right way to do this. But certainly this testing problem now is a terrible one. And so much, if we can get some good testing, we'll really have a handle on the right decisions to make. And without that, we're flying a little bit blind. And I'll now proceed to transmissibility. So there's something called an R0 out there. And what that is, it turns out to be a big number. It's a big number, and I think the public should understand this number. And it's if you have, let's say, of influenza, and the number for that, the R0 on that, is allegedly 1.2. That means if you have this, you are going to pass it on to 1.2 people. And that means the next person will pass it on to 1.2 people. It'll just spread throughout the whole world.
So if it's anything under than 1, it burns out.
That's right. And so what's happening is when you see all this social distancing and the ideas of trying to keep people apart and just stay locked down in your house, what that means is the person that has the problem is that R0 is going to drop below 1. He's not going to be able to pass it along to anyone. So if you're locked up in your house, he just can't do that, and it will gradually, rather quickly die out. So one of the things going on right now, and this is an important number, I'm not sure how much the public has been exposed to it, but it is it's the R0 number for control situation. So in New York, allegedly, these numbers are going down. So the R0 number is under 1. I mean, it's 0.5, 0.6. And you could almost plot this out with these models. Well, if it stays like this, the virus will not be here in 6 weeks or 8 weeks. So that turns out to be the big deal. Now, just to discuss this R0 deal, which is a big, huge thing for the public to think about, that's what they're trying to do. They're trying to drop this under that number. Now, a question that then comes up is how infectious is this just in a state of nature? How does it compare to influenza A and B? The initial numbers were out there were something like 2.6 being twice or 3 times, almost 3 times, as infectious as regular garden variety influenza. Well, these numbers are still kind of shaky as to how transmissible it is. There are issues about it. And the question comes up, and this is a big deal right now because I think in Georgia, the idea is we're starting back with slowly opening tattoo parlors and beauty salons.
Which seem exactly the wrong things to start with.
Well, we could think about it. I mean, we could think about this. And we get into how the virus could be transmitted. And once again, I'm somewhat out of my field, but okay. But point number 1 is, maybe we discussed this slightly with Dr. Kattner, is this 6 feet arrangement. Stay away from someone for 6 feet. Well, why would you do that? You're not touching the person. So presumably when a person is breathing in and out, the respiratory flora is just being spread out into the air. And when, for instance, in choirs, when people sing, the flora goes out even a greater distance. As it goes out, there's a diminution of the distance out there. So if it spreads like that, if you're 6 feet away, I don't want to get too complicated here, there's an R square effect. So right here, I don't know, there are 100 these little viral particles, and out here, there are 10, and out here there's 1. It's going out that light, but with the viral particles diminishing, so that a lot depends on what happens with the small little viral particle gives you inhale it, how your body can resist that, you need enough of the particles generally to cause an infestation or an infection. But that's one of the deals that people are trying to handle. The other thing is what happens when you cough or sneeze, and that goes far out there. It goes 25 feet, tremendous distances. So the 6 feet thing is, it's maybe a useful arrangement, but it's sort of a pick a number kind of thing. It's sort of a pick a number. I don't know if it's 5 feet or 7 feet, or if somebody sneezes at 20 feet.
Yeah, it's like over-engineering. I could engineer you a bridge that could handle, in San Francisco Bay, that could handle any earthquake that could possibly be conceived. But the cost of doing that.
Yes, that's what we can finally sail the ship.
It's the downside, yeah.
Well, so the 6 feet thing, okay. So that's presumably one way things are being spread, and that's I would say there's a question about how it is that it's transmitted. What's the way it's happening? So people, I think most people would say sneezing, coughing. That's a really huge thing, and the little aerosol hangs out a little bit. Also, the little aerosol particles land on other objects. So they're maybe right here, or they're on the cup. And the next question is if you go through the world and say you go to a restaurant, and you're some distance from people, and however, are there little viral particles on the table? And if you touch that, are you then going to go to your face, and then your hand is going to touch this? And somehow you're going to put it on your face, which people do.
People don't even.
You can't stop doing that, and that's the reason they want to stop the transmission from the table to your hand, up to your face, and then into your respiratory tree. So this is some of what's going on, and the question to ask is, and this is still up in the air slightly, is how long do those particles hang out, and on what substances do they hang out, and how many does it take to do it, and then can you deal with this? Well, presumably if you wash your hands a lot, that's the big way these particles are moved along. And you could take, as my wife does, she certainly is keeping things clean if we're around. She rubs everything down, the cups. And so if you do that, that should minimize the transmission issue. But it's still not it's not a knowable. The science is not so hard on this whole transmissibility story, although it's the CDC and everyone is recommending isolation to get that R0 number down. And if the R0 number stays down long enough, then presumably the number of people that have it, just to give you an example, if I have it and I don't press it on and I survive this, I'll be immune to it after some period of time, several weeks later. My body would have knocked the virus off. There's no virus here anymore, and there's no way it could spread. It's just there. So isolation makes the virus go away, drops the transmissibility. And that's the discussion right now about opening up, is to how, if you then reignite the story, what's going to happen? You're going to get back into another story.
I would throw in one complication, since we don't know who's got it because of the problems with testing, then that throws a monkey wrench into really nailing down the transmissibility question. Because if you don't know if somebody's got it, how do you know whether or not he's transmitting it? That messes up your figures.
We can pursue this, and then we can sail the ship, segue, as they say, into how lethal it is. So the story out there, and this is a big question. So the first stories that are appearing, you may recollect this, that these guys at the Imperial College in London were saying, well, millions of people will die, billions, and the models are going back and forth. And a lot depends on how lethal the infection is. Well, it's certainly it is a bad actor. I mean, on the story from the battle lines, from the front lines, in the medical center, just dealing with patients that are out there, it is a very, very brutal problem. And if particularly you're an older person with many comorbidities and you get this and your immune system doesn't respond, it can be an extremely devastating end-of-life experience. So how lethal is it? Well, the initial story was that this was millions of people will die, and the question is, and making the assessment of this, what is the denominator? And so the numerator are the deaths that are listed, and maybe we can examine just the denominator and the numerator story about this virus. So the denominator are all the people that have had this and presumably lived with it. Nothing has happened to them. They've come through the world. And the numerator on top are the number of people that have died with the disease. So the initial number coming out there were 2 to 3%, meaning that if many, many people get it, many, many people are going to die. Well, as those numbers have been refined, this is one reason to do the antibody testing, and this becomes germane for decision makers. If 20% of the people already have had this, if already in the U.S., let's say 50 million people have had the virus, and they didn't even know they had it. They've come through it, they're just fine, they're walking around, it was like a little cold, and it's had no impact on their life, and that's a huge number, then that should be a fact of consequence for decision makers. And so that needs to be understood. Now the numerator on top of this is the number of people that have actually died with the disease. Now there's a debate about what that number is, and many people would say thousands of people have died with this and it has not been recorded. So this number is very, very high. So instead of 30,000 deaths in the U.S., the real number is 100,000 because they just didn't record that as the problem. The testing weren't available in backward places. They didn't think of it. And before the disease actually struck the country, many people died with what was thought to be just regular flu or pneumonia, and that was the way it was recorded. Additionally, there's no question in my mind that in the rest of the world, where there's no testing present and there's such few deaths recorded, many, many, many people are dying with this, and it's not reaching those Johns Hopkins statistics, which, I mean, I'm not kidding about this. They need an asterisk. The politicians are reporting to these numbers. They are so suspect. It's embarrassing. I mean, it should be embarrassing. I mean, maybe it's useful, but to somebody, but they're so inaccurate.
To mess things up even more, it can be off in either direction.
That's
because
correct.
This thing may be transmitting like crazy, and very few people show serious symptoms. On the other hand, maybe in places, and I'm thinking Africa, for instance,
right.
Or places in East Asia that are, North Korea. We're not going to get information.
Right. So these numbers are very. So understanding how lethal it is.
It could go either way.
Is not really truly. We don't really truly have a grip on this, and I think we'll just continue our conversation if we can keep going. I think we'll do that. So in any
20 minutes? 20 more minutes?
Right, we'll keep going. All right. So we'll just make this our conversation tonight.
Okay.
Well, in any event, the numbers on the numerator can go the other way. So, for instance, this is a true story. I won't name names, but there's a person that actually had the problem, had coronavirus, was self-quarantined with terrific heart problems. The person has a cardiac event and dies with a cardiac event, and the coronavirus played very, very little role in it, that's fair to say, but it's been recorded as a coronavirus death. And what the CDC is doing, and they say this on the national television, I mean, the big conferences, anybody that dies that has a diagnosis of coronavirus, no matter what no matter what the actual cause of the death is. If you just have that, you had the blood test and you died with, I don't know, a gunshot wound, whatever, or you fell out of a building and you had it, they're going to record that in their statistics as a coronavirus death. So
well, surely they break it down, and I haven't looked at the morbidity and mortality report. I need to read that more carefully, but I mean, it seems to me that they would naturally break it down at least into three categories. Number one, you got it and you died directly from it. Number two, you got it and it exacerbated a condition, or you got complications from it and died of the complications. And number three, you got it, but it really didn't have anything to do with killing you. You got hit by a bus or something.
Well, unfortunately, in regards to this, Buck, is they don't do it that way. And so the complexities of an autopsy report is quite complicated. So the way these autopsies are put there, what's the actual cause of death? Well, it's heart failure, or the heart stopped, whatever. Cardiac arrest, okay, that's the end of that. But the complexities of actually going through the events that are often multifactorial for the autopsy and extracting knowledge from that is a quite tricky process. So it requires a lot of skill, and it's often pretty imprecise. So now we're left with the vagaries of these numbers. So there we are. We are not sure what the deal is, and the decision makers are now trying to decide what to do. And after having sailed our ship through those 3 points, I think the fourth point to discuss would be, what should you do about this? What are you going to do as a decision maker at this point in regards to dealing with this coronavirus outbreak? It's quite complicated. And so there's teaching that goes on with the epidemiologists, the way they handle things. And the first thing is, once again, it's not what I do, but they sort of, if there are just a few cases out there, they try and isolate the people, and they do investigations. And if they find out, oh, you've been exposed to the person, they isolate them for 2 weeks or so. Well, if they have community transmission, in other words, and this is what happened with the coronavirus, people are out there, and then these cases just popped up out of the blue with no obvious transmission. They just got it, and so that just meant it was in the community, which turns out to be a big deal. So that strategy doesn't work. So the next thing in the epidemiologist textbook is that you go into mediation. So that means you're going to try and drop that R naught number down. If you don't do anything, that number is going to go from, I don't know, R2 to R5. I mean, it'll just really devastate everybody. And that's what happened with these terrific die-offs we've seen. So you have a situation, you can say Northern Italy might be an example, or just pick New York. So you have a very high population density, very high, people are, with it 25,000 people per square mile in New York City, just really, the whole population of Macon would probably fit in 2 blocks there. Millions and millions of people there, huge amounts of contact, people going in the subway. Additionally, they're multi-generational households. So the younger people are out there doing whatever, and the older people are in the household, and they seem to be the people at risk. And so that's sort of what's happening. We have a big number of deaths that happen like that. So what are you going to do? You just try and you have lockdowns. So locking those people down, particularly in that environment, is quite reasonable. The question is, and this is sort of what decision makers are brooding about, is suppose you're in a place where you're a farmer, and you're a South Georgia farmer, or you're out there, and I mean, maybe you see some people occasionally. I mean, you go into town, you might see your brother-in-law in the barbershop, whatever, but it's not like you're routinely in a subway. And so the number in those places, it's going to be, with everything else being equal, be a small danger. That would be a problem.
It's funny that you should mention that, because if you look at the figures in Georgia, and of course Albany turned into a big hotspot, Early County and Calhoun County that are in the southwestern part of the state,
yes,
within about 30-minute drive of Albany. They've got the same, and not per capita, but absolute numbers, they've got the same number of people infected in those counties as in Bibb, with a far lower population.
Yes,
in farming communities.
Well, that's right. And so what happened was which is another story about the timing of doing things. So the farmer people got it, I think, from these rural counties, from Albany. People there, they live in Albany, they go back, and so the actual infection, if one could say that, took place in Albany, and their residents are out in the country a little. So the point of contact were in these urban areas. So, for instance, if you're going into Atlanta to eat, I mean, where it's a pretty urban area, there are high percentages of things, and you go there, there's more of a chance of something happening with everything else being equal. The other point for a decision maker to consider is that how dangerous this is. It's for older people. That's where the danger point is. If you looked at the statistics out of New York City, New York State, where the number of people, that's the epicenter of the U.S. infection, that's where it is, that's where everyone is dying. The number of people, of the percentage of people that have died with that are under 70 without substantial comorbidities is 1.2%. 1.2%. That's not to say that people don't die just that are healthy young adults, or they can die, or young children can die. It's still certainly possible. The other point about this is the numbers of people that are, and there's some pretty good statistics out of Scandinavia, the number of people that are that are school children that have the infection are not too many, and there have been no deaths, actually, no school deaths in Sweden, which has kept their schools open through the whole story. So it may well be.
But they've also got they got an infection rate 10 times higher than the other.
Well, it's complicated. So, it's complicated, but the general population is doing pretty well. Where the hit is happening for decision maker, or this is the real death center, would be nursing homes, older people, and that's what took place in Sweden. 88% of the deaths there are people over 70 years old, and that's the way everywhere. That's the danger. So if you're a decision maker, you're sitting there thinking, what can I do? We've got some problems here. Well, point number one is the traditional thing to do from the point of view of science or medicine would be you mediate this, you just keep people down, lock them down. But if in this circumstance, it's out there everywhere. So everybody already has it. It is quite ridiculous to lock people down. Everybody has it. They've already been exposed to it. Younger people are not at risk. And so that would be something you'd have to brood a lot about, depending on the numbers you got.
But that's a big if.
And what you would do is you would certainly, there's every evidence to really isolate the population at risk, which would be people in nursing homes or anyone that has an impaired immune system, anyone getting chemotherapy for cancer, let's say people that have AIDS, anyone with just real bad lung issues, real bad lung problems, all of those people need to be under substantial restrictions. I mean, I think that's reasonable. If you looked at, as these numbers appear, as you get numbers that say it looks like most of the people have it out here, and everything is cool, and so we can get back to normal. Now the other, as we get into decision makers, what they might want to do, the other big factor in this, which can be understood and obtained, is with getting herd immunity. So what that means is everybody has the infection, they've had it, and one person is exposed. Okay, let's say I'm going to infect 2 people. That's a big number. But the 3 people that I meet they're all immune.
Yeah,
you
can't find the 2 people to infect.
And allegedly the number is about 60%. So the decision maker can say, give me those numbers, give me those numbers. So now we've checked New York City, and 60% of the people there have had the infection. 60% have. that means that R naught number is going to be really low, and we can open everything up and not worry about it. And that's been the strategy in Sweden and other places like that. Now, so decision makers saying, well, let's get some numbers, let's isolate the older people, and we'll discuss that. Is it appropriate to try and get restarted and get rolling again with whatever we need to do here?
Well, I need to throw in a problem with that. You're looking at the mortality rate of what, 1.2.
Yeah.
Our this week's guess is 1.2%. All that evolves. But what percentage of people pull through only with extreme measures, ventilators, and,
we can talk
tremendous
about
resources?
Right, we can talk about that.
So,
I'll get to that. All right, if I can. So the takeaway message is: decision maker is saying, okay, well, let's get the herd immunity. Let's get some numbers. As soon as everything is open, we can get rolling again. And you could consider the chances of something happening with casual social interchanges. One of the big deals out there, I think, are masks. So you can rub things down, you can wear gloves, but I believe masks are a really big deal.
And would this be a good opportunity?
Yes, I believe you're going to discuss that.
I'm show and tell.
I knew we'd get to this. All right, now let's discuss masks.
Yes, masks are, I was having trouble finding masks, so I found a way to do this.
Are those your socks, Buck?
This is a completely clean, unwashed, or unwashed, good heaven, unworn sock.
Okay.
So if
Right,
there's no other way of doing
So if anyone wants to make their own mask, okay.
Yeah, you can do this with 4 cuts. So I hope I can show this to the camera. So
don't cut yourself, Buck.
You cut the ends
careful.
off the sock. So you got one end gone, and you've got another end gone. That's 2 cuts.
Yes.
Now for the 3rd cut, you go halfway up there.
Yes.
And then you go halfway up there. And I'm shedding sock material all over the studio. But with that,
wow, that is so cool.
4 cuts. Yeah, it's not pretty.
How did you? No, I believe that's quite clever.
I found it on Facebook. I mean, because everything on Facebook is absolutely
I believe
true.
if you want to try to buy that,
So,
you would certainly. It would cost you a lot of money, and that looks.
Absolutely.
Now,
so I'll give you this for $20.
Oh, okay. And you know, a lot. Well, they're masks, and they're good masks, and they're bad masks, and it depends on how you catch these particles.
Yeah, and obviously this is not going to filter out a virus. What this is going to do, going back to the earlier comment, is to prevent me from projecting as much.
Well, that's right. And so the takeaway message is these N95 masks their little catchments are small enough to protect you, and
the millipore stuff.
So if you're walking around with a mask, what you're going to, if everybody has a mask, that means that the occasional person out there that may have the disease is not going to pass it on. I mean, to you, you'll be protected, but you're not. By wearing the mask around, the little viral particles can still swim in there. Additionally, what can happen with these masks, if you keep them on too long, well, they're sort of soaked.
Germ factories.
They're right. Yeah. So you don't want to you want to clean it or wash it, and there's a real art form to that. Well, wearing a mask would be a good thing. Isolating people would be a good thing. Getting these numbers would be a good thing. Paying attention to big social events would be a big thing, where thousands of people are jammed in there. That should be cautious. One-on-one contact with people, being careful, that's probably a useful thing. Grocery stores have worked out fine. There hasn't been any particular issues. Beaches have worked out fine. So there are lots and lots of things that could be restored, and I'll let it go at that. That would be a good thing to do, and that's a whole nother subject, getting back to work and how to do that. I will now just talk, as we end our conversation, about what's going on with putting people in the hospital and what happens. Well, there's statistics are out there, but huge numbers of people are going into hospitals, and the incidence of this of having the virus is a substantial number. And so I don't doubt there are just lots and lots of people around here in Georgia that have had the virus. They've already had the infection. Or it's going, in their case, going to be a very mild one, and they won't even seek attention.
Well, I'll call you on that. You don't doubt it, but we just don't have by your own admission, we don't have the numbers on that.
No, but
we just don't.
Well,
so there
are some stories out there, like the U.S. Once it's in the community, once a few people are out there, the The USS Roosevelt, 5,000 sailors, over 600 of them have the virus. And the French aircraft carrier, the Charles de Gaulle, a much more de minimis structure, may I say. Only 1,700 people on that carrier. And that carrier, it's going through the population. And 1,200 of the sailors, over 50%, have tested positive for it. So I would imagine the numbers are going to be up there. Let's see, more statistics. I think they did some pregnant women, and they're just doing blood tests, and 20% of those women had antibodies that already had the infection, and we'll see. But what I'm getting into is you can expect those numbers to increase. They're out there, and in Georgia, I mean, I think most modelers say that many people are going to just have the infection. Almost all of them will be okay. No treatment will be necessary.
Yeah, based on as we're taping this, this is coming about 3 days after Governor Kemp has announced the graduate. Right. So we're about to become the experiment.
That's right.
We'll find out one way or the other.
And I mean, the Swedes have already been the experiment, yes. And that's another. And I think the issue is still out there, but the Swedes are very confident that their plan's going to work out just fine, which I'll discuss.
Except for the people who've already died.
Well, the people in nursing homes died. You want to say it
they're
that
still
way.
People.
Well, yes. Yeah. I mean, obviously. And I'm a senior citizen myself, Bucky, and so I would be at risk. Maybe not you yet, but getting there. So the older citizens.
My wife certainly. She's not got good lungs.
Oh, okay. All right. Well, so we have to be careful.
I guess what I would say, and I'm not an alarmist.
Right.
But yeah, I do recognize that people have to get back to work. They've got to earn a living, and that right. is certainly a consideration here. But I would say the only way to prove the fearmonger is right is to relax all the restrictions and have 100 million deaths. And I'm not sure any reasonable person will
Well, I'm not sure that's the case, but I'll discuss that a little bit. So in any event, and that'll be my final point, I think. So the takeaway message is what happens now with all these people that are, and this is what the modelers say, the numbers are going to go up a lot, and people are going to most people will get colds. They won't notice it, or they might not know. Most people. There'll be a percentage of people that are going to have relatively substantial symptoms, and this can be a very difficult thing. Those people say, okay, I've got some shortness of breath, I'm febrile, I have a dry cough, I don't feel good, my body's aching, and I'm sick. Well, those people are going to come to the hospital, and then they're going to, for those reasons, they're going to be admitted. And once they're admitted, they're going to get supportive care. And the question comes up, is there any kind of treatment that could be employed right now for this group of people? And there are some treatments that are out there. There are antiviral things. There are a lot of things are being tried right now for these people. So most of the people admitted, they kind of sailed through this. They didn't do that great, but they came out of the hospital just fine. Some of those people are going to get sicker and sicker, and they're going to get some substantial treatments. They're going to get some oxygen. Sometimes they do like the sleep apnea meds. You get a little positive pressure ventilator, getting a little bit, but not being intubated. And there are antiviral agents that have some hope in doing this. And then there's the anti-malarial drug that's out there, which people get. The question is how useful it is. I don't know. And the antiviral stuff, once again, not very good papers, but that seems to work. Another thing is getting antibodies. So you can give antibodies from another person that's had it, and that seems to have some benefit. And then the other thing that can happen is, this pretty interesting story is TPA can be given as these people start to get into more and more trouble. One of the things that happens in their lungs is they get these little thrombotic problems in their lungs, and that stops the little villi that where the interchange between oxygen and your bloodstream occurs. That makes those non-functional. So there's some medicine that's being attempted and tried, and it seems to be having from the front lines seems to be having some benefit. So there are lots of medications and lots of treatments that are coming out of this, like World War II and blood transfusion. Mm-hmm. Lots of things are happening for effectively treat people. Finally, the story is with treatment, you can put people on ventilators. And it depends on circumstances, but there's a point number one with people on ventilators. It turns out to be a long siege, many weeks of being on a ventilator. Secondly, once you're in these circumstances, the death rate is quite high. It's a very high death rate. Depends on statistics, 60%, 80%. So it's a very difficult situation. Lots of resources happen. So a substantial number of people are headed in that direction, and no one knows the number exactly. The question is, there are enough ventilators? The people need to go where they need to go, and putting a system in place to send people where they need to go. That's an issue that's out there. We can hope things are going to work out well. So that's sort of a statement about the treatment arrangements. We can hope that things will get better and better. And as so much attention is being focused on this, lots of new treatments, lots of new ideas. And so that's kind of where we are. And then I will just make one or two last comments. Comment number one is, if the strategy is, let's say, we're going to lock everyone down, and the strategy is going to be, we'll let the virus die out. So that's the traditional way that the preventive medicine doctors would play this. We have this infection in Macon. We're going to lock the place down, and then 6 weeks later, 3 months later, no one will have it. However, no herd immunity has happened. So 100,000 people, we lock the place down for 6 weeks.
And if you don't get every possible source of infection,
everybody is okay.
Yes.
So there's 100,000 people here that are okay. However, and that was, and you could say we got through it. We fly the flags. We flattened the curve. That meant that the hospitals did okay, and now
I wouldn't say you flattened it; you eliminated the curve, and that hypothetical.
Hypothetically, the numbers.
Nobody got sick.
Right. Okay. No one got sick enough to cause problems. Right. However, the deal is a bad virus out there and no herd immunity, and also if there is no vaccine. So we've done this tremendous plan in the country to go through and basically separate out the population. We've done this. We've done all this stuff, and now it is September. And the same exact thing happens, particularly in the rest of the world. So not only here, but people from New York who've had there are tremendous numbers of people up there have had the disease or are out there floating around. The border is porous. People are coming from other countries, moving around. Their relatives live in Italy. So they went to Italy to go to Florence, and they came back, and the same exact thing happens, and the exact same thing occurs. So what you wind up with is this catastrophic event where the world just deals with this. That's without any kind of vaccination, without any kind of herd immunity, with this bad virus out there. It just comes back, and what happens? People then the economy of the world stops. We don't have, no one goes to work. Everyone is locked up in their house, and it goes around the world. Nations get really whacked out under these circumstances. People get a little nutty. Wars happen. You can quote the Bible. The four horsemen of the apocalypse start to ride, and pestilence is a big part of, I guess, these problems. And I'll conclude by saying this: that the four horsemen of the apocalypse have always been part of human destiny in a way: famine, war, pestilence, and death. And these are things that they still are there, and it is very destabilizing how the world responds to this, and it requires a substantial amount of appropriate leadership. That's what I would say about it. And it's very, very complicated to be a leader in these circumstances, particularly with all the political difficulties we have.
Well, I would say that, and once again, to recap what your prescription would be, is that unless we can knock out every reservoir of this virus, at some point we're all going to get it.
Yes.
So we might as well go ahead and throw ourselves out there and develop the herd immunity. And I guess that the basis for that argument is it's for the greater good. It's the way that the human species develops this immunity and beats this particular virus. And so in the long run, that is the best way to benefit humanity as a whole. Just devil's advocate, my response would be, when you're making a sort of Milton Friedman economic analysis like that, in the long run the market corrects itself, in the long run the market goes up. John Maynard Keynes would respond, in the long run we're all dead. That, okay, so let's sacrifice this group of people here for the greater good. And whenever we start talking about the greater good or the people, that always makes me nervous. So,
well, I haven't really sailed the ship in the other part of this, and this is the false analogy that's out there. It's money or your life. So we can all get rich if we let the old people die. No, it's not like that. The money that's being generated just in the world goes to all kinds of good things. There's deferred care right now. So if you can look at the number of people in New York City that cardiac deaths at home are up 800%. People have heart attacks, they don't go to the hospital. So you look at the death rates are doubled in New York with other causes. So the death rate's up a lot and it doubled, and only 50% of that is referable to the virus issue. Every other disease process is going up a lot. So, and not only that, the money that goes into to help people, just a $5 bill that goes to sub-Saharan Africa saves 1,000 people. If those $5 bills don't go there, I mean, that's what's happening. So actually, the strategy that's being employed it's very costly in human lives. If you put here, you put people that are at risk, that are not going to make it through this, through the coronavirus, and then the strategy that's employed to do your best for those people causes on this side of the scale thousands and many more deaths. So and that's the way to think of it, is you've got to look at it. You could forget just to take property out of it or wealth out of it, because that's such an inflammatory concept. People are very nervous about, that's the way some rich person or somebody is in the world is going to take money and injure me in the process. I'm going to be injured by the malefactors of wealth.
I'm not sure it's so much about the rich, because I would say, and I think that this whole thing has been a stress test for American civilization, and we've not handled it very well. That's we could get into that for several other episodes. But certainly a lot of people are casting this as the haves versus the have-nots. But I'm wondering how much of that's just coming from blue collar. I'm not rich, therefore I need to go to work and make a living. It would seem to me that person would certainly come down against the quarantine. He'd say, he'd take care of you, even though he's not making $20 million a year or whatever.
Well, so you could say, I mean, it's complicated. I don't want to get too encumbered in this conversation, but the political interstices of the country are at play at this. So Democrats against Republicans, you're this, you're that. You're trying to injure people. You're not trying to do this. You're not. It's going back and forth. I think the thing to do for both parties is to try and look at the general. Firstly, understand the ethics, the situation, and we haven't gotten into the real cost of these policies. And there has to be a balance. And right now, I think the decision makers have so fearful of something horrific happening. They've tilted in a pretty strong fashion to do this, and it's caused a lot of worldwide disruption.
Yes, and it will continue to do so, unfortunately.
Well, the important thing are to get some statistics, and we haven't gotten into a full discussion about what this policy is costing in lives. So many people are dying roughly with this policy. Yeah. Well, on that note, Bucky, I believe it's about time to conclude our conversation, which is longer than usual. And I wish you well. With no handshaking, but and it was great. It was great the way you made that mask too.
Well, thank you.
Why don't you put it on as we say goodbye here? That'll be pretty good.
I love wearing a sock over.
All right. So thank you so much for being here, Bucky.
Thank you all.
Thank you. Right.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.